My name is David Murray. I'm the Associate Director for Prevention here at NIH and the Director of the Office of Disease Prevention. I'm pleased to welcome you to the 2023 Robert S. Gordon Jr. Lecture in Epidemiology. The Gordon Lecture is awarded each year to a scientist who has made major contributions to research or training in the field of epidemiology or in the conduct of clinical trials. The speaker selection is coordinated by the Office of Disease Prevention, and this is the 28th year that ODP has sponsored the Gordon Lecture. The Gordon Lecture Award was established in tribute to Robert S. Gordon Jr. for his dedication to the field of epidemiology and his distinguished service to NIH. Over the course of 30 years, Dr. Gordon served in numerous senior leadership positions, including Special Assistant to the Director and Chief Advisor for Clinical Practice and Research. Dr. Gordon was an early organizer of efforts to address the emerging problem of HIV/AIDS, and he became a key coordinator of AIDS research. Today's speaker is Dr. Lisa Angeline Cooper. Dr. Cooper is the James F. Fries Professor of Medicine and a Bloomberg Distinguished Professor at Johns Hopkins University Schools of Medicine, Nursing, and the Bloomberg School of Public Health. She's also the founder and director of the Johns Hopkins Center for Health Equity. Dr. Cooper studies how race and socioeconomic factors shape patient care and how health systems with communities can improve the health of populations that experience health disparities. An internal medicine physician, epidemiologist, and health services researcher, Dr. Cooper and her team work in partnership with health systems and community-based organizations to identify interventions that alleviate health disparities and translate them into practice and policy changes that improve community health. Her presentation today is titled, Getting to the Heart of Cardiometabolic Health Disparities. Please join me in welcoming the 2023 Robert S. Gordon Jr. Lecture Award recipient, Dr. Lisa Angeline Cooper.
Thank you very much, Dr. Murray. I'd like to thank Dr. Murray and the Office of Disease Prevention, as well as all of the organizers of the Wednesday afternoon lecture series for inviting me to give this 2023 Robert S. Gordon Jr. Lecture in Epidemiology. The last time I spoke at the Wednesday afternoon lecture series, it was November 2020 for the Dyer Lecture. I had hoped to be with you in person today, but alas, circumstances made it difficult, so I'm again joining you in the virtual space. It's an honor to speak to you today about getting to the heart of cardiometabolic health disparities. You've seen my disclosures on previous slides and the learning objectives as well, which will focus on listing contributors to racial and socioeconomic disparities in cardiometabolic health, describing effective intervention approaches, and discussing key challenges and opportunities in translating evidence into practice and policy. Let's start with understanding the origins and contributors to health disparities. And we've heard a lot about health disparities in recent years because of the huge disparities that were observed during the COVID-19 pandemic, but have existed for quite a long time. So what are health disparities? They are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations, and that's one of many definitions. In the United States, there are numerous populations and groups that experience health disparities. These, the ones listed on this slide, have been described in the National Healthcare Quality and Disparities Report, as well as documented in numerous national surveys and collections of data and extensive research. So we have numerous populations that are affected by disparities. We know that disparities are pervasive across conditions, numerous conditions and populations. They cost our entire society a substantial amount in direct medical costs, but also indirect costs in terms of losses of productivity due to premature deaths. And they've existed for a long time. And one of the things we've known is that these disparities have actually persisted. And even though we've made some progress in some areas, the progress has not been dramatic. And then we had the COVID-19 pandemic that began in 2019, 2020, and that shone a bright spotlight on these disparities and magnified them. Today, we're going to talk about cardiometabolic health disparities in particular. Why talk about cardiovascular and cardiometabolic diseases? It's because these are extremely common conditions. They include cardiovascular diseases, diabetes and chronic kidney disease, and cardiovascular disease, as you know, includes coronary heart disease, stroke, hypertension, congestive heart failure, as well as numerous other cardiac and vascular conditions. These conditions combined share multiple common risk factors, including hypertension, obesity, high cholesterol, and dyslipidemia or abnormal cholesterol levels. They're exceedingly common, and they're widely considered to be the leading causes of death worldwide. For example, just in the United States, we have cardiovascular disease that affects about 40% of our adult population over the age of 40. Coronary heart disease affecting about 20 million individuals, hypertension, 116 million people, stroke, close to 800,000 individuals. Diabetes, we're talking about 8.7% of the adult population, or 28.7 million people, and chronic kidney disease, about 37 million people. So just in the United States alone, these are diseases that inflict a large burden of illness and premature death in our population. They also affect several generations within families. They can develop and be made worse at different points during a person's lifespan. And they are also the leading contributors to racial and income disparities in morbidity and mortality. So if we look at just the current state of cardiovascular health disparities, just over the past few years, what we can see from this statement that was published by the American Heart Association is that the death rates from cardiovascular disease have declined, over the last decade or so. They've been decreasing for all racial groups. However, the rate of decrease has slowed, and it has not been the same across racial and ethnic groups. In particular, you can see that Black Americans continue to have the highest rates of age-adjusted death rates from cardiovascular disease. When we look at what the risk factors are that contribute to cardiovascular disease, as well as some of the other cardiometabolic conditions, you can see that they are hypertension, obesity, diabetes, and total cholesterol. So this snapshot from 2015 through 2016, using data from the National Health and Nutrition Examination Survey, or NHANES, really showed that for hypertension, non-Hispanic Blacks were most likely of all other ethnic groups to have hypertension. For obesity, that was the case for Hispanic and non-Hispanic Black individuals were more likely to have obesity. Same for diabetes, those two ethnic groups, Hispanics and non-Hispanic Blacks. And then for high total cholesterol, the ethnic groups were equally likely to have high cholesterol. This analysis was done basically to look at trends and disparities in cardiometabolic health. So instead of looking at disease, we're looking at what's the state of health with regard to cardiometabolic risk factors over the past 20 years or so. And so what we see is that cardiometabolic health, if you look at these lines on the screen, you can see that it's been poor. If you look at people who have optimal cardiovascular health, you can see that all of these graphs start at 20% or 15%. So very low percentages of the overall population have optimal cardiometabolic health. This has been worsening. And in 2017 to 2018, the most recent period, only about 6% of US adults had optimal cardiometabolic health. There are also disparities. If you look, these graphs are showing disparities by age on the far left, then by race and ethnicity, and then by education and by income. And the way the authors actually measured this was that they used the American Heart Association's health score, and they included updates to that. So that includes things like the measure of body mass index, of blood pressure control, of blood lipids, and the absence of previous cardiovascular disease events. And so what you can see here is that there are disparities by age, by race, ethnicity, by education level, as well as by income level. And that we're not really seeing much in the way of closing of those gaps. And in fact, in some cases, they've actually worsened. So why do we have health disparities? And if we really want to address them, we have to understand the causal chain. And, you know, sometimes we think it's all about what happens on the individual level, but this schematic is just here to remind us that there is a causal chain that begins with systems of power. So when you think about factors that actually influence our lives and our health, they actually begin at a very large level. It has to do with our social norms and beliefs and values and where we invest our resources. And so, you know, things like racism and sexism, classism, ableism, and homophobia, these sort of general beliefs and values around who in our society ought to have certain opportunities and resources, they shape basically who gets to be involved in, and they provide hierarchies of power within our institutions. So we call those structural drivers. So these norms and beliefs determine who is at the top of the hierarchy of our institutions. And as you all know, our institutions determine how we are governed, what practices and policies we support, and what our regulations and laws are. And so those are the factors, these structural drivers are the factors that determine what our living conditions are. And so our living conditions are things like the physical and social environment, the economic environment, and the service environment. So whether we have access to resources like healthcare or social services, for example, whether we have opportunities to work, whether there are good relationships among groups of people in society, whether or not we are exposed to different toxins. And we call these social determinants, but they're really shaped by the structural and systems of power. And that is what determines what behaviors we are able to engage in as individuals. What opportunities do we have to make decisions regarding whether we're going to choose to smoke or engage in healthy eating behaviors, physical activity, whether we're going to use alcohol or drugs at unhealthy levels. Those individual actions are not things that occur in the vacuum. They occur as a result of what opportunities we have based on where we live and the other sorts of resources we have in our lives. And it's those individual actions that ultimately determine whether or not we become ill, you know, and so that determines our exposures that impact our psychological and biological responses and could shape how well we are, whether we develop diseases, whether we are injured, and whether we die sooner than we would if we had optimal exposures. So this is the whole causal chain. And until we understand this and understand that we need to intervene at each of these points, we're never going to solve the disparities problem. So keep this in mind as we move forward in talking about the field of health disparities research, because it really has evolved. You know, early on in disparities research, there was a lot of research that basically described the problem. You know, collected data from people of different racial and ethnic groups. And for a long time, we didn't even have data on certain groups, so we couldn't describe what was going on. But for a long time, the research that we did have was very descriptive. Then we moved on into mechanistic work where we were looking at all these different contributors and what part they played and those sorts of things. And the field has now sort of moved in the direction of interventions because there's an urgency for us to intervene. These problems have been going on for decades and, you know, even more than a century for many of these conditions, more than several centuries. And so it's time for us to intervene, especially as our country becomes more and more diverse, and our inequities by these social conditions have grown. So one thing, this is a slide that I've shared before at this lecture, but just I think it's a good reminder for us that we need a lot of knowledge in order to solve these really complex problems. And that's why, we're fortunate to have institutes like the NIH and other funders that support research on clinical efficacy and effectiveness, on basic biomedical and behavioral science discoveries, and on epidemiology. But this slide is showing that we have developed a substantive knowledge base related to health disparities, but we have a gap between what we know and what we do to achieve equity. And so that gap is really in the area of that we need more transdisciplinary research. As I mentioned to you, because the problem is so complex, it affects so many different systems and aspects of our society, that it's going to take scientists from a variety of different disciplines. It's also going to take efforts to really disseminate and translate the knowledge we do have. How do we get that knowledge that just out of scientific journals and out of, maybe the most highly resourced institutions, and how do we get them out to the communities that are really affected by inequities? How do we make sure the approaches we have are actually sustainable outside of the scientific setting and in the real world? And how do we effectively engage with communities? It's not only about the scientists or the people who are in positions of, institutional power, but it's also about the people who live in the communities that are affected by disparities, because they know only too well what the problems are and what some of the barriers are to solutions. They also know what the strengths are, and much more so than the scientists who may not come from those communities or may not have had the lived experiences of those groups. So this approach we wrote about in a book that was published by the National Institute on Minority Health and Health Disparities, basically on the science of health disparities research. So what are some of the approaches that we do have, that we do know based on evidence that's been collected by scientists over many, many decades? We know that there are three broad categories of approaches that would reduce inequities in health if we simply implemented them. So the three broad categories are creating communities of opportunity, infusing more health into the delivery of medical care, and building political will. So we're going to just go through it in a little more detail. What do we mean when we say create communities of opportunity? Dr. David Williams and I, my colleague and I, wrote about this a few years ago. Well, we know that early childhood development initiatives are effective at improving the health and the developmental outcomes of children. We need to implement them. We need to reduce childhood poverty. We know that that leads to better health in adulthood. We know that enhancing income and employment opportunities among young people and adults improves the health of those individuals and their families. We just know things like increasing the minimum wage, for example. We know that improving neighborhood and housing conditions contributes to better health. Now, that's been shown by behavioral scientists, that many whom have been funded by the National Institutes of Health and the National Science Foundation. The other thing we know is about infusing more health into the delivery of healthcare. We know, for example, that improving access to care improves health outcomes. We've seen that from the children, the insurance program for children, CHIPS. We've seen that from the Affordable Care Act, when insurance is provided, that it does improve health. We know it's not the only thing, but we know it is an important component. We know that emphasizing prevention and primary care is important, rather than waiting until people get sick and then trying to treat all the complicated issues they have at that point. There's so much science that we have about how to eat healthy, how to keep our blood pressure down. We know which medications work. We know that we should wear seatbelts when we drive. We know that we should wear helmets when we ride a bicycle. All of those things are prevention. We know how to prevent and screen for cancer. but it's not actually being emphasized and provided to everyone. We know that there are disparities in the quality of care. We know some of the factors that contribute to that, whether it be poor patient-provider communication or sort of inadequately resourced institutions in certain communities. We know that we could do a better job of addressing patients' social risk factors by connecting healthcare with other resources within communities. We know that diversifying the healthcare workforce improves outcomes. So there's so many things that we know about that we just actually need to do. And then when it comes to building political will, a lot of these things haven't been documented yet, but certainly there's a lot of wisdom, around the fact that if we increase awareness of inequities, that we can mobilize communities into supporting policies and policymakers that would address inequities. We know that getting people more civically engaged is better for their health, for individual health, as well as for the health of entire communities. And we know that reducing stereotypes and prejudice will reduce things like crime, violence, and other forms of harm. So these are some broad approaches. The other thing we know is that it's going to take more than one thing. And so this diagram, this is an interventions model that is a multi-level intervention model. It's based on sort of the socio-ecological model, which sort of acknowledges the fact that health is influenced by factors at multiple levels. So we want to intervene on a particular problem. We need to move beyond addressing individual patient behaviors, for example. This is a model that focuses on healthcare, but this model could be replicated for any other setting, for an educational setting, for an employment setting, for a community-based setting. And so the fact is that people's behaviors are shaped by their social connections and their social networks, by the organizations in which they operate and they work and obtain services, and by the policies and the community resources that are available to them in their communities. So we don't have to intervene on all of them all at the same time, but we know, and the research has shown us, that intervening on only one level very rarely accomplishes the goal of reducing disparities. So the field has now moved towards testing multi-level interventions. And thanks to NIH in particular, and many other funding agencies, but NIH in particular has been very supportive of the testing of multi-level interventions and looking at how those interventions influence key interactions within the environment or in the organization in which we're operating, and then subsequently how those interactions then influence outcomes. And it's important to note that we are now focused not only on clinical outcomes, but on organizational outcomes, such as costs, on patient experiences, on the equity of services, all of those things that matter to individual people, to communities, and to decision makers. So when we look at cardiometabolic disease in particular, if you look at all these multiple levels of influence, you can see if we get more specific, one might choose on an individual patient level to focus on an issue such as adherence to medications. On the provider or clinical team level, there might be a focus on something related to communication skills or related to some other technical skills in the delivery of care. At the local community level, one might choose to focus on something related to food availability. If it's not changing the actual availability of food, it's like changing how individuals can obtain access to food within their environments. And then similarly, on the other side of the diagram, you can see that there are multiple areas in which one might choose to focus on. And obviously, the choice of what to intervene upon is influenced by what is known in the existing research. That research on contributors to health disparities and on mediators will let you know which of these factors contributes the most and is most amenable to change. And that's where you want to then direct your efforts. So I was fortunate in 2010 to be awarded a P50 grant from the National Heart, Lung, and Blood Institute to establish a center focused on health equity. And so we've been in existence since 2010, and now so we're in our 23rd year. And our mission is to promote equity in health in populations that have been socially marginalized by a three-pronged approach: advancing scientific knowledge, educating and training leaders, and then partnering with communities. And so this photo just shows our community advisory board, which has also been active since 2010. And so back in 2010, we wrote a paper about what was involved in creating this transdisciplinary research center and some of our early lessons learned. And we wrote about the multi-level interventions that we tested. And so some of them, this particular center, we were focused at this time on hypertension disparities. We had one project, Project Redship, which was primarily focused on health system approaches, but we intervened at the level of clinical and frontline staff, as well as on the level of patients. We intervene on the organizational level by providing additional staffing through a registered dietitian and pharmacist to address uncontrolled hypertension in primary care patients. The 5+ Nuts and Beans trial intervened more on the food accessibility issue in Baltimore City. We had people from a food desert, which we know is an area which lacks healthy food options for people. So what we did was provided dietary coaching and a food delivery to the local library, because many of the folks that were participating in this trial had no access to fresh fruits, vegetables, nuts, and beans, part of the DASH diet, which we know is effective for reducing blood pressure. And then we had a third study called the ACT study, which included community health worker outreach to patients with uncontrolled blood pressure, the provision of home blood pressure monitors, and some focus on problem solving. So intervening there on the social support environment, as well as on the healthcare environment and the individual. So we had some interesting lessons learned. We showed some effectiveness in those 3 studies, not as dramatic as we would have liked. And some of the lessons we learned were applied to our next generation of studies, which now what we're doing is, for example, the health system approach now also incorporates the community outreach, because we didn't reach so many of the people who were eligible for our program by focusing only on the health system or the people that were already engaged in the health system. On the food delivery approach, we learned that there are particular people who are at higher risk and could benefit more from the healthier diet. And so we're focusing on those higher risk individuals who have early kidney disease and doing the dietary coaching and food delivery with that higher risk population. So these are our 3 most recent trials, are the Rich Life Project, the 5+ Nuts and Beans for Kidneys trial. And then we also have a trial that we conducted in Ghana, which tested task shifting from physicians to community health nurses in a setting where there was a limited number of primary care physicians to care for patients. We also provided home blood pressure monitors and a cell phone app for tracking of patients' blood pressure and diabetes outcomes using health information technology. And we were doing this actually before the pandemic. And wow, so many lessons learned from that study that can be applied now in the United States. So as I mentioned, our center has this 3-pronged approach: our engagement with community through our community advisory board and with numerous health system partners, our research arm, and then our training arm, which focuses on providing courses and symposia and individualized mentoring opportunities for the next generation of researchers and leaders in health equity. So I'm going to tell you now, focus more on a specific study on the Rich Life Project, so that you can get a little bit more of an idea of exactly what I'm talking about. So this study, Rich Life, was funded by PCORI and NHLBI. It's a cluster randomized pragmatic trial that included 30 practices in Maryland and Pennsylvania. We enrolled 1,820 adult patients, approximately 63 per practice. The patients had to have uncontrolled hypertension plus at least one other comorbid condition, which included diabetes, depression, high cholesterol, heart disease, or tobacco smoking. And we compared 2 interventions, one which we called the standard of care plus intervention, which actually focused on providing skills and knowledge and resources to frontline clinic staff and system leaders. And then the second approach, collaborative care, stepped care, which included all of the components of standard of care plus, but also incorporated a care manager, community health worker, and a specialist team that would be available virtually to deliver individualized care to patients. And so let me tell you a little bit more about those interventions in a few minutes, but our main outcomes at 12 and 24 months were blood pressure control and change in patient activation. And we did analyses that were planned, pre-planned subgroup analysis, with the primary one being looking to see if we could, if the intervention would reduce disparities in cardiovascular disease and in hypertension levels that were present at baseline. So briefly, the standard of care plus intervention included standardized blood pressure measurement training for all frontline staff and clinicians. It included a hypertension best care and best practices training delivered by audiovisual, a web-based training program. It also included a learning network for health system leaders. So this was like a series of quarterly seminars on key topics. And then we had a hypertension dashboard that was provided to all of the practices, extracting data from their electronic medical records and giving them feedback on how providers and how the clinic overall was performing with regard to achieving blood pressure control metrics broken down by race and ethnicity. So this is a very active sort of comparator arm. And so here is what we did for the standardization of blood pressure measurement. We had a screen and confirm protocol, and we introduced automated blood pressure devices to all of the practices. We had staff training in person and for the trainers, and then the trainers trained the frontline staff. We also had observation visits, or what we called a fidelity audit, over the period of the study. And then, as I mentioned to you, the hypertension best practices training. So the screen and confirm protocol is basically that every patient is screened for blood pressure using an automated blood pressure device, and using these steps, you know, for positioning the patient and for using the device correctly. The confirmation piece is done only for patients who have a screening blood pressure that is above the threshold. And we used, at the time, we used the threshold of 140 systolic because that's what the guidelines said at the time. Now they've changed to 130, but that's where we started out. But if people had a high screening blood pressure, the staff were trained to then confirm it. And the confirmatory measurement basically allows the device to collect 3 back-to-back readings with a 5-minute wait in between each reading, and then those readings are averaged. And then if the patient still had a high blood pressure reading after the confirmatory measure, then they would be deemed to have uncontrolled blood pressure. So again, the leadership intervention involved an introductory session, quarterly webinars, as well as coaching calls, but the coaching calls were only for the more intensive arm of the study, not for the standard arm. Again, several topics all the way from things like addressing inequities on your dashboard, working with community partners, addressing a patient's social needs, psychological safety for your employees, addressing implicit bias, several different topics of interest that you know, we developed basically based on input from our stakeholders. Now, arm 2 of the trial again had all of those standard of care elements, plus, like as I mentioned, the monthly coaching call for the clinic-based champions, a dashboard review that was facilitated by the clinic champion. So not just having the dashboard available, but actually having a process by which to review that dashboard and to come up with you know, improvement plans. And then the addition of a care manager to the team. So the care manager was added to the team, which included the primary care provider and the patient. And the care manager then had the option of also what we call stepping the patient up. If the patient was not improving in blood pressure or in their other associated condition over time, care manager could incorporate the support of a community health worker or engage with a specialist core, which was available through virtual consultation. The care manager also had access at all times to a behavioral health specialist. And so in most cases in this trial, what we did was to use existing staff within the practices and train them because we wanted this to be as pragmatic and realistic as possible so that it could be as sustainable as possible. And so the organizations we worked with were responsible for identifying and hiring these individuals, and then the research team worked with them to train them and to oversee them over the course of the project. So the community health workers really provided community-based contextualization of care for the patients in this intensive arm. They would support patients in reaching their self-management goals by helping them to address any social and environmental issues. We're thinking about things like food insecurity or housing insecurity or financial problems with getting medications covered. They would also support patients in advocating for themselves with their healthcare providers. They would help them navigate the healthcare system. And so some of our patients in this intervention arm received this sort of more stepped up intensive approach. Others who may have had other more medically complex situations, the care manager would opt to consult with a specialist team. And so we had specialists in hypertension, diabetes, psychiatry, preventive cardiology, and smoking cessation, and they would discuss the patient's case and provide recommendations back to the primary care team. So I'm going to tell you a little bit about some of the implementation process measures, and then we'll move on to results. So what did we do to determine whether or not our implementation was actually successful? For the blood pressure measurement piece, we had a number of different measures. One of them was called the terminal digit zero preference. And so that really lets you know if you can think of blood pressure devices as having numbers on them, right? And between each number, there's numbers from 0 to 10, right? You have 130, 131, 132, 135, 137, you have 140. Well, we know that when people don't use automated devices, that oftentimes in measuring blood pressure, there's uncertainty around what the measure is. And so people tend to round the numbers to 0. And so what we were looking for in our measures of blood pressure that we obtained from the electronic medical record was that our 0 preference would go down. And indeed it did. The 0 preference of the measures before we introduced our training was around 16%. It was reduced to about 11% after our training, which is more what would be expected, because if you have numbers from 0 to 9, you would expect 0-digit preference to be somewhere around 10%. So 11% is not bad. We also had a median blood pressure measurement sort of performance score or preparation score, like things like whether the patient was seated correctly with feet on the floor, whether the arm was elevated at the level of the heart, whether or not the patient was not speaking and had emptied their bladder. And so we looked at the median blood pressure measurement preparation score before and midway through training, and then a year later. And we found improvements in all of those scores. Now, there were some sites where we didn't show improvements in the middle of the study. And in that case, we would send our team out to do troubleshooting and some retraining as needed. So at the end of the study, we did show improvement in pretty much across the board in our practices. We also saw high levels of adherence to the 5-minute rest period before the confirmatory measurement. So that was something that there were people who were not allowing that 5-minute rest when we first did the training. And after time, we saw that they did improve with that. And then we also saw improved adherence to recording the average of 3 readings for confirmatory measurement. So the blood pressure measurement program is a success story. Now, there are some practices that were certainly scored better than others. So we know that there are some unique organizational factors that could contribute to that. For example, we had a champion who was really engaged in this process, we definitely saw greater improvements in the blood pressure score. So here's some other measures of implementation. For care management, we saw that our care managers conducted over 4,000 visits. So 88% of the patients who were randomly assigned to this arm did attend at least one care management visit, and 77% attended 2 or more. Most of these visits were by telephone. As you know, this study began before the pandemic, but it did occur during the pandemic. So I believe that that probably influenced the mode of delivery of the intervention in some ways. But people who couldn't meet the care manager in person did meet them by phone. And the care managers spent most of their time talking about medical conditions, which makes sense because most of them were nurses, some clinical social workers. And then they spent a lower amount of time talking about lifestyle barriers and social determinants of health. In terms of referrals to the stepped care program, we had expected about that the nurse care managers would refer about half of the patients to a community health worker. Well, we saw about a referral rate of about 30%. And in terms of referral to the specialist intervention, we saw a referral rate of only 2%. Now you can see that it varied quite a bit across health systems. So these 30 practices were in 5 different health systems. And you can see, for example, there's one health system, C, where there was a very high referral rate for community health to patients to community health workers. That was a federally qualified community health center, and there were patients that had high social needs, but there was also a receptivity to having community health workers be part of the primary care team. Now, some of the barriers we heard about were related to things like people just not being used to working with community health worker, feeling like the nurses feeling like they already could address a lot of the issues that the community health workers were addressing, just sort of inertia in changing existing practices. For the specialist referral piece, we learned that a lot of the nurse care managers were concerned that suggesting a referral to the specialist core might be offensive to the primary care provider, especially if they saw that the patient was already receiving care from specialists. So they were hesitant to make those referrals. And despite the fact that we did a lot of explaining to them around the fact that the specialist core was not to replace the patient's usual care, but just to provide additional support, there was still a lack of uptake of that intervention. So let's talk about the patients who were referred to the community health workers. Community health workers conducted a total of about 600 visits. 91% of the people who were referred to a community health worker had at least one visit with a community health worker, and just over half of them had 2 or more. Most of these visits were done by phone. We did have some community health workers actually go out to people's homes to take them blood pressure measurement devices, or to try to, find them if they hadn't heard from them, and to accompany them to other appointments and things like that. But again, with the pandemic, it was much less than we had expected. Now, the community health workers talked about a variety of different things, surprisingly a lot about medical conditions, but this was probably more about things like how people could get access to their medications and to other medical supplies, and not so much about the medical condition itself. And then a lot of those conversations were also about how to use a home blood pressure monitor, which the community health workers were very helpful in teaching patients how to use home blood pressure monitors. And then again, you can see a lot of their time was spent dealing with social determinants of health, getting people access to food, to housing, getting them signed up for health insurance, making sure their utilities could be paid, things like that. So we're going to go on to the results because we don't have that much more time left. But so who are the patients we enrolled? You can see we enrolled over 1,800 patients. They were on average about 60 years old. About 60% were women. We had almost 60% who were Black, 33% white, about close to 10% Hispanic. We had about a quarter who were on Medicaid insurance. There were no differences between our intervention groups when we adjusted for clustering, although you can see that there is a slightly higher percentage of Medicaid insured patients in the collaborative care stepped care arm. There were also no differences, no substantial differences clinically in the intervention groups, with most patients having slightly elevated systolic blood pressure, diastolic being only 85.5 on average. And that's because to be in the study, you simply had to have a systolic blood pressure of 140 or greater. You can see there were many comorbid conditions represented, with the most common one being hyperlipidemia, followed by diabetes. And again, no substantial differences between the two groups when we adjusted for clustering, but a somewhat of a difference in the prevalence of coronary heart disease, with that being a little bit higher in the standard of care group than it was in the CC stepped care group. So what were our 12-month outcomes? We successfully engaged, as I said, 1,800 patients. Our follow-up rates were approximately 80% in both groups, so no differences in follow-up between the two intervention groups. We did have some people who withdrew from the study, but most of the patients who we didn't find were the ones who were deceased or simply moved out of the area. So what did we find? We found that about 60% of these patients attained blood pressure control over the 12-month period. So out of the 100% who were uncontrolled, 60% attained control over time. And we didn't see differences between the two intervention groups, although you can see that at baseline, blood pressure control was basically lower among Blacks than it was among whites and Hispanics, but we didn't see any differences in blood pressure control over time. Sorry, this isn't at baseline, this is at 12 months. So we saw disparities in blood pressure levels at baseline, and unfortunately, those were not closed at follow-up, although everyone did obtain blood pressure control over follow-up. Not everyone, but they were similar control rates over time. What we did do some pre-planned subgroup analyses, and I'm only showing you a couple of them here because these are the ones where there was a difference. So among patients with Medicaid, we saw that, patients with Medicaid actually had a higher likelihood of attaining blood pressure control when they were in the collaborative care arm than patients who were not on Medicaid. And a similar pattern was seen for people with coronary heart disease. Those who had coronary heart disease were more likely to attain blood pressure control in the collaborative care arm than people who didn't have coronary heart disease. So when we looked at the reduction in systolic blood pressure over time, it was clinically and statistically significant in both intervention arms, with a reduction of 14 to 15 millimeters of mercury in systolic blood pressure in both groups, and a reduction of anywhere from 6 to 7 millimeters of mercury for diastolic blood pressure. The difference between the two intervention groups was only significant for diastolic blood pressure, where patients in the CC stepped care arm had a slightly greater improvement in diastolic blood pressure than those in the standard arm. In terms of patient-reported outcomes, we saw improvements in patient activation in both groups that were not significantly different between groups. We did see improvements in patients' assessment of chronic illness care in both groups that was slightly greater in the collaborative care stepped care arm. So what did we learn? We learned that an enhanced standard of care program improved blood pressure control substantially among patients with hypertension and associated comorbidities. When we added a collaborative care piece to that, we saw similar benefits for blood pressure control overall and blood pressure levels. We did see some greater improvements for patients with Medicaid insurance and patients with coronary heart disease in that intervention. And we saw some greater improvements in patient experiences of chronic illness care. So we concluded that to reduce disparities in hypertension, health system leaders and policymakers should support multi-level interventions and reserve the most intensive approaches for patients with complex medical and social needs, and that there is a need for further research to address and elucidate implementation barriers. So we have a few minutes left. I'm going to talk about some of our challenges and opportunities. So one of our, I think, our real strengths and continued opportunities is in the extensive engagement with a broad group of stakeholders. We had people from all levels of the health system who were involved in giving input into the design and implementation of the trial, as well as we had patients and community members on our advisory board and leaders of community-based organizations. We had the involvement of 5 health systems that included FQHCs. We included a diverse population that was at high risk, and we used existing staff. So there are plenty of opportunities here to use existing resources and staff to bring about changes. Some of the challenges were using an active comparator group made it somewhat difficult to determine, to detect a difference offered by, adding sort of the patient-facing component. There may have been some contamination between the practices that were in the same health system. We had some implementation barriers, which we can go into more detail with in our discussion period. We did use clinic-based measurements of blood pressure for our outcomes. So we didn't have research staff, but we used the clinic-based measurements. But we thought that that was a good way to use pragmatic measures that would actually be used in clinical care. And with the training we provided and the fidelity to the training, we really felt comfortable about the quality of the blood pressure measurements. We did have some disruptions during COVID-19. All of these are real life things that happened. And we had some limited statistical power for some of our subgroup analyses. But we know that relationship-centered approaches and engagements is important when we know that some organizational factors can constrain successful implementation. So we really want to learn more about those through our some of our implementation measures. We know that staffing and financial issues were a problem for many of our settings. We know there was a lot of turnover. There were some competing priorities, including COVID-19. There's organizational inertia, and there are some individual attitudes and behaviors of staff members that have to be addressed still. So I'm going to wrap up with just a snapshot of some of our current research to advance cardiometabolic health equity. And so we have been funded recently by NIMHD to conduct a series of studies in the Mid-Atlantic region that will address not only hypertension, but other cardiometabolic conditions. And so we're going to be testing the effectiveness of these interventions using community-based research and patient-centered outcomes principles. And then again, using this knowledge to promote changes in practice and policy across Maryland and the Mid-Atlantic region. We're focusing on socially disadvantaged populations in a number of different communities across the state, rural as well as urban, looking at a variety of different cardiometabolic factors. And we have these 3 trials. So one of them focuses on people in the pregnancy and postpartum period. So again, trying to intervene with another high-risk group. We know that maternal mortality disparities are driven in large part by cardiovascular and cardiometabolic inequities. Another study focused on individuals with early heart failure, and one again focused on hypertension, diabetes, and chronic kidney disease, but this time really using telemedicine and telemonitoring approaches to engage patients and to improve their self-management procedures. So when we're doing this, we have to be mindful of the fact that our work should be informative to policymakers. And I just wanted to say that it's been an honor and a privilege to provide advice to policymakers in Maryland, as well as to serve on national academies committees, to provide congressional testimonies on these issues, to provide briefings to policymakers at all levels during COVID-19, and also to contribute to policy briefs and reports, whether it's about changes in hospital performance and measurement, reward systems, and whether it's like advising on how to advance and sustain the community health worker workforce. And we see multiple opportunities for future policy engagement. For example, in the area of implicit bias training, that's been mandated in so many states. What can we do to make sure that implementation is going to be successful? Legislation to offload financial burden on patients, support for community health workers, and then also health system collection of social determinants data and how they use it. So we know that it's not only about research, but it's also about engagement towards action, because it's going to take translation of science into practice and policy if we actually want to achieve health equity, which is when every person has the opportunity to attain his or her full potential. And I want to just acknowledge all the many people, colleagues across the spectrum, community partners, staff members who do a lot of the day-to-day work, partners in the health system and community, whether they be organizations, again, more investigators and staff, and again, our community advisory board, over 65 people who have been committed to this work for more than a decade. And I'm going to close just by leaving you with an option if you're interested in reading more about this or learning more about this in my book, Why Are Health Disparities Everyone's Problem? There's a discount code that is shown on the slide and that will be provided to you later. And I'll close and say thank you.
Thank you, Dr. Cooper. Terrific presentation. We have time for one or two questions.
There might be a little feedback, Dr. Murray. Maybe, I don't know if you can mute the video cast, if you might be watching on that.
I'm going to try to.
I think we fixed it, whatever you just did.
Okay. Let me pose this question. Multi-level interventions are much more complicated than interventions that operate at only the individual level. What advice would you give young investigators, postdocs, grad students who want to learn how to develop multi-level interventions? What are some of the most important considerations?
Well, I think what's important, first of all, is to get the right training in the scientific principles that will inform the development of these interventions. Get the right training and mentorship to really sort of immerse yourself not only in doing the science, but also engaging with the people who would be implementing the interventions, who would be using the interventions. So you actually understand how to apply what you've learned kind of conceptually in a practical sense. Those are the two most important things I would say. So obtain formal training, mentorship, and experiential learning.
And how about learning to evaluate multi-level interventions? That's perhaps even more complicated than developing multi-level interventions.
I agree.
How can these people learn about those methods?
Well, I think they can learn by collaborating with multidisciplinary teams. For example, I learned a lot of how to measure communication quality from a social and behavioral scientist mentor. And I've learned more about how to measure sort of economic outcomes from my colleagues who are health economists. I have a colleague who is an organizational behavior specialist, and I've learned so much from her about how you measure organizational attitudes and performance. So, you can start out being an expert in one thing and just collaborating with other people to learn about their methods. And, over time, a junior person is not going to necessarily be able to implement a multi-level intervention immediately, but you can put the pieces together and you can become part of a team so that you learn from the other people around you.
I could not agree more. It is a team sport, and one person can't learn all the pieces. I want to thank you, Dr. Cooper, for a terrific presentation, and thank our audience for great questions and a lively discussion. And I want to thank everyone for joining today's lecture.